Thank you. We shall now go on to our next speaker, Dr. Sachin, who's very eminent and who will be dwelling on the approach to a patient with optic disc edema. Dr. Sachin is a professor, neurological sciences, ophthalmology, visual sciences, program director of the neurology residency program, director of neuro-ophthalmology and ocular electrophysiology from Nebraska Medical Center. He's also a chair of NANO's curriculum committee, besides all else, and has received numerous teaching awards, including the NANO's Merit Award, AO Achievement Award, AN Excellence in Teaching Certificate. His research interests include development of novel teaching methods, ophthalmic biomarkers of neurological diseases, clinical trials in neuro-ophthalmology and the impact of visual impairment on cognition, and his clinical interests involve all forms of visual disorders, including afferent, efferent, and visual perception. We are really enlightened to have you with us, Dr. Sachin, and we look forward to your talk. Dr. Murugan, could you stop sharing your screen?
Okay, sure. Thank you.
Thank you, Dr. Chitra. Can everybody hear me?
Yes, we can.
Yeah, sure.
But I think Dr. Murugan has
1 minute.
Yeah, it's okay. Okay. Dr. Sachin has shared his screen.
Yes, my screen is up, I think. It's so good to see familiar faces, colleagues and friends in neuro-ophthalmology and some of my teachers and mentors from my time at RP Center. So thank you for the invitation. So today I'll be talking about an approach to patients with optic disc edema. I have no relevant conflicts of interest for today's talk. So the optic nerve head is really unique because it is the only part of the central nervous system that we can see in the physiological state. But it is also a structure that has some anatomic challenges that make it susceptible to injury. So you can see the axons take a 90-degree curve as it enters the scleral canal. There is an abrupt transition from a non-myelinated to the myelinated state in the retrolaminar region. Also, these axons, which are initially exposed to high intraocular pressure, are now abruptly exposed to relatively lower intracranial pressure in the retrolaminar region. And this pressure differential is called the translaminar gradient. So when we do an ophthalmoscopic examination, by and large, this is what the optic nerve looks like. Either it is normal, it is swollen, it is pale, or it is cupped, most commonly in glaucoma, but also in other optic neuropathies. So why does the optic nerve have the swollen appearance? And we think it's because of axoplasmic stasis. So when the normal milieu of the optic nerve is disturbed by either mechanical forces such as raised intracranial pressure or low intraocular pressure, then there is inflammation at the anterior part of the optic nerve, or as Dr. Prema described, toxic metabolic states or ischemic states, there is axoplasmic stasis that may or may not be visible to us through ophthalmoscopic examination. So when I see a patient with disc edema, this is a very broad schema I follow. This is not meant to be exhaustive, but mostly as a guide. Step number 1 is to determine if the disc edema is true or not. Step number 2 is a vision loss or not. Step number 3, is it painless or painful? And step number 4, which I often use, is it unilateral or bilateral? So now I'll describe a few cases about how to approach a patient in various scenarios. The case number 1 is a 26-year-old obese female with blurred vision and headache, has a big BMI 55, blood pressure is normal, visual acuity is 6/9, pupils are reactive, you can see papilledema, you can see enlarged blind spots. So here you have bilateral disc edema, no vision loss, true disc edema, and we think this might be papilledema secondary to high ICP or hypertensive disc edema. So the next step in our evaluation is going to be neuroimaging. And here is a mid-sagittal MRI section, and you can see the sella turcica is enlarged. The optic nerves are also patulous. The MRV showed stenotic transverse sinus, all suggestive features of elevated intracranial pressure. More importantly, there was no tumor or space-occupying lesion. Lumbar puncture showed a significant elevation of CSF opening pressure. 50 CSF contents were normal. And so she satisfied the criteria for idiopathic intracranial hypertension. treated with acetazolamide, and she lost 10% of her body weight by about 8 to 9 months. And when I saw her roughly 9 months later, her papilledema was essentially gone. Case number 2, you now have a 79-year-old female with acute and complete loss of vision in the right eye. She has headache, and she says that her temples feel sore. Her vision is bare light perception in the right eye. Left eye is 6/18. It's not normal. And her pupils are abnormal with a right RAPD. So when you palpate her temporal arteries, it is tender. So here, I don't think there's much of a differential. Clearly, this patient has arteritic ischemic optic neuropathy with a high suspicion for giant cell arteritis. Maybe you can consider inflammatory optic neuritis as probably your number 10th or 11th in your differential. So arteritic AION was suspected. She had sky-high ESR and C-reactive protein. She immediately received IV solimedrol, 500 milligrams, 3 doses, underwent a temporal artery biopsy. And as you can see from these pathologic specimens, the artery was occluded by thrombus. There was necrosis of the internal elastic lamina, mononuclear cells, and you can see the giant cells. So this confirmed a diagnosis of giant cell arteritis. She was put on long-term oral prednisone with a very slow taper, and this is before the era of tocilizumab. Luckily for her, and I've not seen this happen many times, her vision improved to 6/18 and 6/9 by about 1 year. Case number 4. So this is a 45-year-old healthy female with acute painful unilateral loss of vision in the right eye for 1 week. Her acuity is 3/16 in the right eye, 6/6 in the left eye, right RAPD, full eye movements, but with pain. Neuro exam was otherwise normal. Clearly, you can see optic disc edema on the right side, normal disc on the left side. And as you move this along this pathway over here, she has vision loss, painful optic disc swelling, and you suspect an inflammatory optic neuritis. She was imaged, and here you can see contrast enhanced orbital sections showing a long segment enhancement. But more importantly, you can also see enhancement of the soft tissue within the orbit. So you're suspecting atypical optic neuritis. She received serological testing, and the pertinent positive was for MOG immunoglobulin, which is positive in a titer of 1 in 100. She was treated with IV solimedrol for 5 days, a very long, slow steroid taper. Unfortunately, she had 2 relapses and had to be put on rituximab as an immunosuppressing treatment. She remained recurrence-free at about 18 months. Last case, 68-year-old female with a 2-month history of progressive blurred vision in the right eye. Vision is reduced to 6/30. There's right RAPD, full eye movements and alignment, but she has a right trigeminal V1 anesthesia with loss of corneal reflex. Optic disc was swollen on the right, normal on the left. You can see that there is a large central scotoma in the right eye, but you also see a sort of a temporal defect in the left eye. So your lesion is now localizing to the junction of the optic nerve chiasm, probably the cavernous sinus because of trigeminal involvement. And as you again go along this path, there is vision loss, painless, with other neurological signs. You strongly suspect a compressive or infiltrative lesion. You are going to get imaging. And so on imaging, you can see a mass that's originating on the planum sphenoidale. You can see it surround the optic nerve. You can see it invade into the cavernous sinus, compress and elevate the optic chiasm, which is barely visible over there. So she undergoes surgical decompression. The disc edema resolves, but unfortunately, her vision does not improve. So in summary, axoplasmic stasis is probably the cause of optic disc edema from various different conditions. If you see an obvious large anterior optic nerve swelling, then that's where the lesion is. And the lesion could be ischemia, could be inflammation, or could be mechanical compression, such as from high intracranial pressure. Now, if you see bilateral optic disc edema, then it is most likely due to high intracranial pressure, high blood pressure, or other systemic metabolic conditions. For me, imaging is indicated in almost all cases of optic disc edema. especially those where you have other neurological signs and symptoms. Thank you, and I'm open for any questions.
Thank you very much, Dr. Sachin. That was a wonderful talk, as expected. Questions, Rohit?
So, Dr. Sachin, why did you start IV methylprednisolone for a patient who you suspected as arthritic ischemic optic neuropathy? I mean, would you think that it's now that we shift to IVMP the moment we suspect, or would oral still be adequate?
That's the big controversy. So I think in the US, most of us have shifted to either 1 or maybe 3 doses of IV steroids immediately after diagnosis. And the goal is to prevent the other eye or other systemic complications and then transition to a long-term oral steroid. That being said, there is no convincing data as far as I'm aware of where high dose oral versus IV makes any significant difference. Prem, do you have any comments about that?
I would agree. I think it's the one time that hospitalizing the patient and putting them on 250 milligrams every 6 hours is actually something I like to do, because bioavailability is then more even over that 24 hours. Plus, these are elderly patients who are at high risk for steroid-induced complications. And so it's nice to have them under the care of a hospitalist who can manage those things. There are some data that suggest that if you start the patient initially on IV versus oral steroid, that their total steroid dose over time may be lower. But it's unclear if that has clinical significance or not. And now, especially since we in the US have the ability to use tocilizumab, we are transitioning patients with GCA off of their steroids more quickly in any event.
Prem and Dr. Bhattu here. Do we see a greater incidence of AION, significantly greater incidence of AION among Caucasians versus Indians? It is not very common for us to make a diagnosis of arthritic AION in India.
Arthritic AION, right.
Yeah, not very common.
Whereas
when I was training in Australia, we used to have a list of at least 2 or 3 temporal artery biopsies every day.
Yes, Dr. Bhattu. So we do know that it is higher incidence in the Caucasian population, especially those of Nordic descent. And this is shown through studies that was done from the Mayo Clinic.
Yeah, because my first temporal artery biopsy was done in Australia as a professor of ophthalmology being taught by a first-year resident there.
Yeah, I can tell you that, I spent 3 years doing neuro-ophthalmology at RP Center, and the number of cases I saw in 3 years, I probably saw it within 1 month of my fellowship in the US.
Correct.
Absolutely, absolutely.